Hello and welcome to the topic Acute Pancreatitis in the module Gastroenterology and Hepatology. By the end of this topic, you should be able to define acute pancreatitis, outline the etiology and pathophysiology of acute pancreatitis, describe the clinical manifestations of acute pancreatitis, discuss the investigations which can be carried out for the assessment of acute pancreatitis, and finally, discuss the principles of management of acute pancreatitis. Let's get started. Acute pancreatitis is defined as the inflammation of the pancreas. It can be understood as a multitude of events which occur in a cascade that gives rise to the dysregulated pancreatic function. Acute pancreatitis is a sudden inflammation of the pancreas. Causes in order of frequency include gallstone impacted in the common bile duct beyond the point where the pancreatic duct joins it, heavy alcohol use, systemic disease, trauma, and in minors, mumps. A vast majority of cases in the UK are caused by gallstones and alcohol. A popular mnemonic that is used is get smashed. G for gallstones, E for ethanol or alcohol, T for trauma, S for steroids, M for mumps. Other viruses also include Coxsackie B, autoimmune such as polyarteritis nodosa and also Ascariasis infection, S for scorpion venom, H for hypertriglyceridemia, hyperchylomicronemia, hypercalcemia and hypothermia, E for ERCP, and D for drugs such as azathioprine, mesalazine, didenosine, furosemide, steroids and sodium valproate. Before we understand the pathophysiology of pancreatitis, let's understand the physiology of the pancreatic function. The pancreas is a gland located in the upper posterior abdomen. It is responsible for the insulin production and the secretion of digestive enzymes leading to carbohydrate, fat, and protein metabolism. The major area of the pancreas is involved in the exocrine function, and the remaining minor part is involved with endocrine function. The pathophysiology of acute pancreatitis is characterized by a loss of intracellular and extracellular compartmentation, by an obstruction of pancreatic secretory transport, and by an activation of pancreatic enzymes. In biliary acute pancreatitis, outflow obstruction with pancreatic duct hypertension and a toxic effect of bile salts contribute to disruption of pancreatic ductules with subsequent loss of extracellular compartmentation. Alcohol induces functional alterations of plasma membranes and alters the balance between proteolytic enzymes and protease inhibitors, thus triggering enzymatic activation, autodigestion, and cell destruction. Once the disease has been initiated, the appearance of interstitial edema and inflammatory infiltration are the basic features of acute pancreatitis. The accumulation of polymorphonuclear granulocytes in pancreatic and extrapancreatic tissue and the release of leukocyte enzymes play an essential role in the further progression of the disease and in the development of systemic complications. So what happens in acute pancreatitis is that, as mentioned, there is an imbalance in the pancreatic cellular homeostasis. This can be caused by injuries to the acinar cells, which then further impairs the secretion of zymogen granules. This then leads to interstitial inflammation and edema, proteolysis, fat necrosis, and sometimes hemorrhage. As mentioned in the causes slide earlier on, among the trigger factors for this to happen include alcohol use, gallstones, and certain drugs. Symptoms of acute pancreatitis include abdominal pain, which is the cardinal symptom, characteristically dull in nature, which occurs sudden in onset and gradually becomes more severe until reaching a constant ache. This pain is often located in the upper abdomen and may radiate through the back. Abdominal pain is usually accompanied by nausea and vomiting. Other uncommon physical signs one can look for and may be associated with severe necrotizing pancreatitis are the Cullen sign, which is the bluish discoloration around the umbilicus resulting from hemoperitoneum, and Gray Turner sign, which is the reddish-brown discoloration along the flanks resulting from retroperitoneal blood dissecting along the tissue planes. Erythematous skin nodules, usually no larger than 1 centimeter and typically located on extensor skin surfaces, as well as polyarthritis, are among other quite uncommon physical signs that you may look out for. Once we have reached a working diagnosis of acute pancreatitis, some lab tests may help further confirm the problem as well as assess the severity. We can send off a serum amylase and lipase, liver function tests, blood urea nitrogen, creatinine and electrolytes, blood glucose, serum cholesterol and triglycerides, a full blood count, C-reactive protein, arterial blood gas, as well as serum lactate dehydrogenase. Imaging studies play an important role in acute pancreatitis. They are used to clarify diagnosis when the clinical picture is confusing, to determine the possible causes, to assess the severity, and thus to determine the prognosis, and finally to detect complications of pancreatitis. Among the radiological modalities that can be employed in the diagnosis of pancreatitis include abdominal radiography, which has very limited role. The kidneys, ureters, and bladder radiography with the patient upright is primarily performed to detect free air in the abdomen. Abdomen ultrasonography, which is most useful initial test in determining the etiology and is the technique of choice for detecting gallstones. Endoscopic ultrasonography, which is used mainly for detection of microlithiasis and periampullary lesions, are not easily revealed by other methods. An abdominal CT scan can be done, generally not indicated for patients with mild pancreatitis, but always indicated for those with severe acute pancreatitis. An endoscopic retrograde cholangiopancreatography or ERCP can be used with extreme caution in this disease and never as first-line diagnostic tool. Other diagnostic modalities include CT-guided or endoscopic ultrasound-guided aspiration and drainage, as well as genetic testing in certain conditions that predisposes one to have pancreatitis. Let's take a minute and look at this scan. This is a CT image from a patient with acute pancreatitis. Note the diffuse parenchymal enlargement with edema and indistinct margins, which are one of the hallmark characteristics of acute pancreatitis. The goals of medical therapy in acute pancreatitis are to reduce pancreatic secretory stimuli as well as to correct fluid and electrolyte derangements. Management depends largely on the severity. Medical treatment for mild acute pancreatitis is relatively straightforward. Treatment of severe acute pancreatitis involves intensive care. Surgical intervention, which can be open or minimally invasive, is indicated in selected cases. The vast majority of cases in the UK are caused by gallstones and alcohol. It is important to categorize the severity of the disease. Medical management of acute pancreatitis is managed with supportive therapy. However, severe acute pancreatitis require intensive care. And this then includes fluid resuscitation and nutritional support. Antibiotics therapy is used in case-to-case basis. Now let's take a look at the complications of acute pancreatitis, and this can be pretty severe. These include systemic ones such as acute respiratory distress syndrome or ARDS, renal failure, shock, arrhythmias, metabolic disturbances such as hypocalcemia and hyperglycemia, as well as encephalopathy. And also localized complications such as pancreatic abscesses, formation of a pancreatic pseudocyst, as well as pancreatic effusion. In summary, acute pancreatitis is one of the causes of presentation of acute abdomen. It is the inflammation of the pancreatic acinar cells leading to impaired function of the pancreas. Commonest causes are gallstones and alcohol. However, keep in mind other causes too, such as medications or drugs and iatrogenic injuries. Features are pretty straightforward. One should always keep in mind the diagnosis in someone who comes with severe acute abdominal pain or discomfort and actively seek for possible causes. Investigations that may be useful include serum amylase or lipase test. Imaging studies are also useful to look for complications arising from this condition. Management is mainly supportive and to reduce the risk of further progression of the disease. We have come to the end of this topic. Thank you for your time.